Hi, my name is Jess McManus. I am part of the education team here at Professional Physical Therapy, and today we're going to be talking about pain neuroscience education. So let's start with who this is for. We know that 20% of the people on this planet will experience pain persisting more than 3 months at some point in their lifetime, and there's been a lot of chatter around using pain neuroscience ed with these chronic pain patients. But we can also start right away by changing our language out of the gates with even our acute patients. From the ankle sprain to the acute low back sprain, we can talk about pain neuroscience in a way that our patients don't even know we're talking about it, but shifting our language to help move the needle on people who might be at risk for developing chronic pain. So this is a really big topic. We're gonna hit the tip of the iceberg today, and there's lots and lots of resources that you guys can go to, and I've included those at the end of this lecture. So the objectives today are just to talk about how pain neuroscience education differs from traditional patient education, and give you a couple key concepts, and then show you how you can apply it in the clinic starting work on Monday. So again, what we need to understand to be efficacious ourselves and understand the neuroscience of pain is not what we need to deliver to our patients. The information we deliver to our patients is often in small pieces of our language, using words like safe and that's good, pain is good, it's protecting your body, things like that. And we'll get into that more as we get through. So let's talk a little bit about the evidence for education. The clinical practice guidelines for low back pain that came out in 2012 by DeLito and his colleagues have a really strong foundation of evidence for educating our patients. I don't have to go through all the pointers on the slides here, but I want you to notice that the neuroscience that explains pain perception is number 2 on that list. And then if you dig into reading those slides, the overwhelming evidence of education is really to use active coping strategies, teach our patients that it's okay and it's safe to move early on, and really focus on the positive when we're educating our patients with low back pain. Quick overview of other evidence. So there's evidence dating all the way back to the study in 1999 on looking at the difference between educating our patients on pathoanatomical models, explaining the spine, showing the injury that they have to their spine, and this really cool study by Burton and his colleagues split the groups in half, and they took half the patients and educated them on the anatomy of their injury, and the other half they did none of that and just gave them a booklet that focused on positive outcomes with low back injuries. And 6 months and 1 year out, the second group had improved FABQ scores, which is the Fear Avoidance Belief Questionnaire, and overall higher functional outcomes. So interesting information. Doesn't mean we never explain anatomy, but it means we really need to think about the patient that we're talking to and what's the best fit for them. So what is explaining pain? So it's educating our patient on the actual biological process of pain, with the key concept being shifting the belief that pain equals tissue damage to the understanding that pain is the perceived need to protect. And sometimes the brain and nervous system just want to protect us a little too much. Another key concept is that pain is normal. It's a beautiful gift. We need it. When you have appendicitis, you get that horrible pain in your stomach, so you go to the emergency room. It saved your life. Pain saved your life in that scenario. When we talk about acute injuries, that's a classic example. More chronic injuries or slower onset is me sitting at the computer to write up these slides. My tush starts to hurt. I know I need to get up and move around. That's my body telling me to get up and move around. So pain is meant to protect us and tell us information. Here's the 3 key concepts. And we chose these concepts because they really, underneath each of them, encompasses the biggest bulk of what explaining pain neuroscience is. The first one is pain is an output. Second, pain does not equal tissue damage, always. And third is your environment and emotional factors can influence your pain. So let's go with the pain as an output. So I'm gonna show this slide, but I'm gonna just give you a classic example, okay? So we have nerve endings in our periphery, for example in my foot, that are there to recognize potential danger. You guys all know the term nociception, so these are our nociceptor nerve endings. So let's take me walking into my son's bedroom and it's dark, the nightlight's not working, and I step on one of his little toy cars. What happens in my nervous system is that those nociceptors in my foot recognize that I just stepped on something sharp and awkward, and they send a message up to my spinal cord and brain to give it that information. It's my brain's job to decide, is this potentially dangerous? And if it is, we'll send the message down to create a painful response. The interesting thing about nociception is that it is never enough alone to create a pain experience. This means that even with the most severe input in the periphery, that alone is not enough information for the brain to conclude that there's danger and send a pain response. So here's a classic example, if you're not believing me. Phantom limb pain. So the tissue, the foot in this example, and the shin are no longer there. But we know that phantom limb pain is a real phenomenon and that the patient is feeling pain in the tissue that's no longer there. So how is this possible? So remember back to your neuroanatomy classes where you had to look at that picture of the homunculus in the brain, the map of where the leg and the foot exist in the brain? That doesn't go away when you have a leg amputation. So there's even been research on pain after amputation, and it's usually more severe when there was pain before amputation. Meaning that painful experience has been mapped somehow in the brain and it still exists after amputation, which is why you can feel pain without any nociception from that tissue. So spinal cord level. So we kind of started to talk about this already, but those nociceptors send information up the leg into the spinal cord sort of processes them and sorts them, starts to even interpret them, and then continues the information along up to the brain. Brain is like the command center. At the point that that information gets to the brain, it has to take the incoming message from the nociception. It has to take the information that it has stored in memory that's not part of our conscious mind, any other past experiences, for example, that I've had with stepping on toy cars or anything else sharp in a dark room, and the environment around me, seeing my vestibular system, what's happening with my balance at the time, my visual system, what does my vision see? Well, it doesn't see anything because it's dark. Taking all that information in and decide if it needs to protect or not. Ultimately, the brain decides, pain or not. So this is where it gets a little complex, and I'm going to glaze over it, but there's much more information and resources in these slides here for you guys. So the biggest concepts I want you to understand is that we used to believe that there was a pain center in the brain, the hippocampus. That's actually not true. We've proven this with science. The painful experience that occurs in the brain actually occurs in many different areas of the brain that have a day job. It's our areas of emotion, sensation, proprioception, balance. So we call areas that light up when there's a pain experience in the brain ignition nodes. And it may take multiple ignition nodes to light up or fire to create a perceived response or responsive pain, but it's very, very interesting when you delve into the literature. So there's some more information here that you can look into. Second concept, pain does not equal tissue damage. So we all understand that we've seen a chronic pain patient, we know the tissues have healed, but they're still experiencing pain. Let's look at the opposite end of the spectrum, because this helps people to understand it. There's a Lincoln here who I call Happy Shark Attack Boy, but this was a news story I saw a couple years ago, and it was in North Carolina. A teenage boy was swimming with his family, and he got his arm essentially bitten by a shark. And they're interviewing him 2 days later on like the morning show, and they said, "How bad did it hurt?" And his response was, "It didn't hurt. I didn't feel anything." So here's a scenario where there's severe tissue damage. There's a shark hanging off your arm, and you're not experiencing pain. There's lots of hypotheses of why this happens. Some people will say, scientists will say, that this is the perceived need to protect in the brain at its finest. The brain knows that if I give you this pain response, you're not going to be able to fight your way away from the shark, so I'm going to block any pain, sending chemicals down the spinal cord to inhibit any type of reactivity. In that way, you can get out of the water and come on NBC the next day. Some people will say it has to do with hormones in the body. There's lots of different theories on this, and it's amazing that we're still learning about it. There's also lots of literature out there about low back pain, and that up to 60% of people with no symptoms will have abnormal findings on their MRI, disc injuries, arthritis. So here's a scenario where there's tissue damage, or has been tissue damage, but no pain response. One hypothesis on this is that potentially that damage occurred slowly over time, so the incoming information from those nociceptors in the spinal cord was never quite enough to trip the wire or ignite those nodes in the brain to create a pain response. So central sensitization. This is also a really deep topic, but I'm going to give you the basics on it. So central sensitization is essentially when the spinal cord and brain response becomes amplified. Impaired function of descending anti-nociceptive mechanisms in the brain. So these are these really powerful hormones that the brain can send down to the spinal cord to slow the information coming in that might make it respond to pain. They're happy hormones, endorphins and enkephalins. Overactivation of pain facilitatory pathways. So that means the brain has the power to open up nerve endings in the spinal cord and periphery through chemical and electrical reactions to receive more incoming information, more nociceptive information than is actually occurring to the tissue. So obviously you can see how this can result in an augmentation of the response with pain. So up at the brain, you take that information I just told you, right? So let's say I step on that toy truck again, or any other thing that's sharp and painful in the night. If I have central sensitization, there's more nociceptive endings in my foot staying open longer to receive that information at an amplified level. They're sending that information up to my spinal cord that also can have more nerve endings and more nerve sprouting at the dorsal root ganglion to open up the message even louder. And then that information gets to the brain. So maybe I step on a toy car, okay, and that was not very damaging or dangerous to my foot, but because of that amplified central sensitization, the information that gets up to my brain is that I just stepped on a machete. Point up, and that's the information that my brain is getting, and it has to make a decision whether to protect me with pain or not. What do you think it's going to do? It's probably going to protect me with pain, despite the lack of tissue damage. So there's lots of interesting examples in the literature. I'm going to skip this slide for now for the sake of time to get to our third concept. Pain is influenced by context. So I love these two pictures. I much prefer the tropical beach picture, but I want you to take a scenario. Let's say you're walking along the tropical beach picture and you step on something sharp and you don't know what it is. And in this scenario, it's a beautiful day, you love Corona, you're with people you love, and the person you love is telling you a joke that makes you laugh really hard. Then you step on that sharp object. Picture your response there. And now take that same day and you're walking on this nasty looking beach and it's freezing and the winds are whipping and you don't know when you're going to get out of there, but you have to get out of there, and you step on something sharp. What scenario do you think is going to hurt a little more? The evidence tells us it's very possible that you're going to have a little bit more fear and a little bit more pain response on that yucky beach. So now let's get into how we can start to apply this information. The biggest barrier I hear therapists say is, will my patient think this is in their head? Obviously, everything I'm talking about is the brain. So yeah, your brain's in your head, but we have to be very, very selective with our language and how we help our patients understand the neuroscience of pain so that they don't feel threatened by that. So one of the things I've used as an example is a cold. This kind of centralized pain or chronic pain response is simply a biological change in the nervous system. So your pain is absolutely real, and it's just like sometimes when you get a cold, it turns into bronchitis or a sinus infection. Most of the time, when we have an injury, we have a pain response early, and then it slowly tapers off as our tissues heal. But sometimes, just like a cold can turn into bursitis, the pain can persist, and the nervous system has a heightened reactivity, and that we just need to teach your nervous system how to calm that down again. So putting your knowledge to work. So one way to put our knowledge to work and understand where our patients might be coming from is to use some screening tools. So the FABQ, the Start Back screening tool, and the pain catastrophizing tool are great pieces of information that we can gather in the intake and have our patients fill out to get an idea if our patients might have fear avoidance or pain catastrophization. Another thing is the gift of gab, which if you haven't figured out already, I have. Change our language, lay the groundwork at the eval. So if we say to our patients in the initial evaluation, hey, so here's what we think is going on with your back. I want to show you around the clinic. This is our exercise tech. Here's our equipment. When you come in for therapy, you're going to be here about an hour, you're going to get some exercise, we might do a little bit of stretching to your muscles, and we're going to talk a little bit more about the science of pain to help you move along the process of feeling better much faster. How does that sound? Patient says, yeah, that sounds good. So then when you choose to bring the topic up or use some information that you've learned here today, it's not threatening at all. It's expected, and they're interested in learning more often that way. Address your patient's barriers. So our patients have a lot going on in their minds that they don't always share with us. So it's important to ask lots of questions, get to know them, find out what other medical professionals or people they trust have told them about their injury. This will give you great information. They might tell you, my neighbor's a doctor and he told me I shouldn't even be able to walk on the spine that I have. So that's a very strong belief that we need to help the patient understand and help them recognize that they can be active and regain function. Positive inputs to our environment, we can possibly help to control our symptoms of our injury. Great resource by Butler and Mosley is the Protectometer book, and it actually shows this really cool image that patients can use to start to recognize that dangers and safeties are anything in their environment, things they see, things people say to them, things they say to people, their thoughts and beliefs, things they hear. It's really interesting. In the clinic also, graded exposure and pacing activities. So when we meet a patient that has an amplified amount of pain compared to their injury, and we know they can probably do, for example, 3 sets of 10 of squats, with graded exposure, we might start much less than that. We might just teach them about the inherent strength and safety of moving, get them comfortable, and get them to accept that they'd like to try a squat, and maybe you do 5 repetitions the first time, and slowly help to build them up. While we're doing these things with our patients, things that will help is to increase the safeties, or the SIMs, right? Use safe language. Squatting is great. The spine is built to move. Sometimes we have some cool posters that we'll use in the clinic to teach patients about their pain so they can recognize that squatting is safe, or whatever exercise they might do. In the clinic, that's a way to have graded exposure. At home, they can do some practicing themselves. So I think of a patient that I had recently who just wanted to be able to watch a half-hour sitcom with his wife at night. He had low back pain and he could sit through 2 minutes of the show. So I had him put the timer on when he sat down to watch it with her, and then time how long it took. So we knew 2 minutes was his baseline. What he did for graded exposure is every night he promised himself to sit down with his wife, but he didn't try to sit through the whole show because it was too much input into his system and his brain was recognizing that as danger. So the first night he did 2.5 minutes, and he added sims into his environment. He sat in his favorite chair. He had his favorite drink. He chose the show. Those things helped him to build up, and over the course of time he was able to sit and watch TV with his wife. This is one example of a poster we might show to our patients even while they're exercising. So the image on my left shows our body protecting us with pain right before we're at risk of tissue damage. I touch a hot stove, my nervous system tells me that I just touched something really hot, and I pull my hand away immediately to not burn myself if I left it on longer. In this scenario with central sensitization and chronic pain, we have a new version of that. We are protected by pain much, much earlier than there's potential tissue damage. And it's important to understand that because exercising through pain can be very safe, and our patients need to understand that, depending on the case. So steps for getting started. I'm gonna let you guys go back and look at these, but I've kind of put a little step-by-step guide of things that you can use based on what we've talked about to help hold you to it and keep you accountable for trying to integrate this into your practice. So at the end of the day, what we're trying to do is, this beautiful slide says, is maximize the health of the tissues, the nerves, and the brain. Training the brain and the body can help our patients get better more efficiently and enjoy the process. I've included a bunch of really cool resources for you here, guys. The bottom one, I encourage you to watch, tamethebeast.org. Explain Pain Supercharged is an awesome resource for clinicians, and here's some other ones here. Thank you so much for listening. Hope you got something good out of it.